Hi, Jeremy Faust, medical editor-in-chief of MedPage Today. Today, I want to talk about an article that I've written on my newsletter, Inside Medicine, and it's called "When Will One-Way Masking Be Safe Enough for Everyone?" The point of this piece is really to look at mask guidance because, as you probably all know, in late February, the CDC changed its guidelines on masking for the country, and it really brought up a lot of responses. It really was popular in some areas and unpopular in others, and a lot of people felt that it was too soon. There we are at the end of the Omicron wave, still over 1,000 deaths a day. Was it too soon? My gut was that it might be, but I didn't really have a great way of assessing it. But when you look at the CDC's two stated goals, one, keeping hospitals safe, and two, protecting the high-risk populations, could they achieve that with their new framework? And I think that with respect to keeping hospitals safe, in other words, keeping cases low enough that hospital capacity wasn't threatened, I actually think that their model can do that. I say that because their model resembles, in a lot of ways, the hospital capacity circuit breaker dashboard that my team and I built and I've discussed here before. So I think that for their first goal, the CDC actually has a good idea. I share it. And that you can, if you wanted to tie mask use to hospital capacity, there is a framework that can be very powerfully utilized in that way. But the question is, does that protect everyone? What about the immune compromised? And I didn't feel like their model really explained very well if that was possible, nor did I get a sense from the most cautious members of the public health community, people who really worry about the disabled community, people who worry about immune compromised people, as well we all should, but the loudest voices on this were clearly saying this was not good enough. But I didn't really have a sense of what would be good enough. When can we take off our masks? When would it be safe for someone who's immune compromised to walk around one-way masking so that the rest of us wouldn't have to wear masks in all public situations? So I thought, well, maybe I can generate one. Maybe I can come up with my own metric, a trial balloon that I'll put out there and see what people think, see it as a starting place. When can mask mandates go away such that an immune compromised person with absolutely no protection from the vaccine could basically go about regular life for 4 months and have less than a 1% chance of getting SARS-CoV-2, the virus that causes COVID-19. And what I ended up doing was to try to figure out how to get an itinerary of living. You could tweak it, you could add things and take things away, and it's in my newsletter, but it does include some important things, including one big trip to the airport, like going to a major airport, checking in, flying, getting your bags, going to where you're going, and then whenever, a week later, going back to that same airport all over again, those two airports. It includes going to a medium-sized church twice a month. It includes a weekly trip to the grocery store of medium size. It includes a monthly trip to the pharmacy. I threw in a bunch of things, and I did not include things like going to work in a public place every day. I did not include indoor dining. So then I went through the numbers and I made a bunch of assumptions that people would be one-way masking and they'd be wearing N95s. And I assumed that the N95 would be 90% effective for a couple of hours in terms of keeping out virus. I assumed that not everyone who is infected is contagious, and also that not every time you come into contact with someone do you necessarily get an infectious dose in your face, masked or not. I also built in one really important assumption, which may be the weak link in the chain here, which is that I assumed that everybody who couldn't be vaccinated, that they could get Evusheld, which is a medication that's prophylactic, shown to decrease COVID infections by 78%. I actually assumed that it would only work about half the time. But I did assume that everybody would get it. And that's a big, huge hole in this, because if we take that out, then all of a sudden we're going to have to change the itinerary. The bus trips have to get cut in half. It has to be a smaller church. The grocery trip has to be to a smaller place, or maybe someone has to help you. You order your groceries. There's just fewer things. You can't go to that as big of an airport, or you can only go every 6 or 8 months. So there are problems with this model. It's not perfect. It's meant to be a trial balloon. But the biggest thing is, in order to get us really safe, I had to give every person who's immune compromised an N95 mask, and I had to imply that they had access to Evusheld. So that's a big if. And the ultimate outcome here is that, yes, we actually can get to a number. And it turns out that the number that I back calculated was pretty conspicuous. It ends up being a little bit under 50 cases per 100,000 people per week. And that might ring a bell, that number. It's just uncanny, because the CDC's old system was broken down into 4 categories: low, medium, substantial, and high transmission. And if you, under the old system, if you were substantial or high transmission, if you were in that region, you were supposed to do indoor masking. And if you were moderate or low, you could do it optionally. And interestingly enough, the cutoff is 50. So I came up with, actually just sort of accident, the same number that the CDC's old guideline would have implied. So if we are under, as a community or as a society, under 50 new cases per 100,000 people in the population over a week period, then the outcome would be, given Evusheld and given one-way masking by the immune-compromised folks that we're thinking about here, that we would have that those people would have a less than 1% chance of getting COVID in a 4-month period, which is pretty good. We countenance that risk, and actually more than that risk, in the past during the peak of flu season. When you think about 50 million flu cases that are out there, nobody's masking back then. So I do think we should actually raise our standards. We shouldn't go back to that. If you're an immune compromised person, or you take care of one, or you live with one, look, masking in the peak of January in a bad flu season is probably going to be a good idea, regardless of what happens with COVID. We should have been doing that before. But do we have to do it 365, 24/7? No. And this is the idea, that we can give ourselves something to shoot for, something objective that actually keeps everybody safe. So I'm convinced that the CDC's current metric may leave people out to dry here. At the same time, I'm hoping that this framework, this idea of, well, what does it really take to protect everyone around us, could actually be a better goal to shoot for. And baked into this as well is an idea that if we get above that threshold, that maybe optional masking would actually be fine, because people like me wouldn't mind throwing the mask on. I think a third, a half, even more of the population will throw on masks when we're in a risky situation. And then we really wouldn't have to do mask mandates until we know for sure that even that isn't keeping the risk to immune compromised people under 1% over 4 months. And that's when I would say a mask mandate would have to go back into effect. So this is the idea. It's basically reverse engineering a metric based on a concern. And I'm curious what everybody thinks. It's on Inside Medicine, which is my newsletter. You can go check it out and leave comments. I think this audience in particular probably has a lot of ideas to share with me about the holes that I haven't thought of, and whether or not this is a good framework. So I welcome that, and I appreciate you hearing it out. So thanks for joining me today, going through this. I look forward to your comments, and see you next time.